read the question first before we start.
80-year-old man presenting with acute chest pain after performing 12-lead ECG. What is your field diagnosis? Is this patient having a STEMI? Which coronary arteries, if any, is involved?
So before you start saying anything, you see how at the bottom, right, the hospital machine could actually print you a longer strip of those individual leads. So what I'm circling here, right, the top one is V1, the second one is V2, and the next one is V5. So the hospital, right, and even your cardiac monitor, depending on the brand, you could get a longer strip. The reason you do this is how you get your underlying rhythm. So here, I want to see, right, I want to see my underlying rhythm. Actually, right here, right? So I could look at V1, I could look at V2 here, right? Sorry, V2 was the one above it. Right? So I could interpret my rhythm. Lead 2, the reason why we look at lead 2 is that normally that's where, that's normally where we obtain our rhythm strip. So that's why they look at lead 2. Can you look at V1? You can. Can you look at V5? You can. So as long as you have long enough strip to do that. That's what I was talking to you about. And was it Lindsay, right? You asked me how we go about interpreting. So just to show you here, right? This lead 2, let's say if I was first trying to interpret my rhythm, right? I would look, and you guys are going to learn the box method. So the box method, you find where your EKG falls on the box. This is going to be 300, right? So the heart rate falls between 75 and 100. Let's say maybe heart rate here, let's just say it's 85, right? And then what I'm also looking at is your PR interval, right? So your PR interval is 0.12 seconds to 0.2 seconds. So this PR interval from here to here, right, should be within one box. So let me see if I can do this. I'm gonna see if it's above. So it falls like almost like within those boxes, right? So this is what you're gonna measure when you are doing it, and you want to make sure it's within the box, because if it's longer, then you may have a first degree heart block, right? But I think we are right in the ballpark, right, as you see here. This I would interpret as sinus rhythm for my underlying rhythm. That step is you want to do before you start interpreting your 12-lead. You want to get the underlying rhythm first, and then you're going to go into your 12-lead interpretation. All right, so go ahead, Brian.
Right, so I see ST elevations in lead 2, 3, and AVF with reciprocal changes in lead 1 and AVL. So this is probably corresponding to an inferior wall MI.
Okay.
From an occlusion on the RCA or the circumflex. And yeah, I would also do a right-sided, a 15-lead EKG to rule out any posterior MI.
Yeah, very good. So if you did the 15 lead after you're doing your standard, I would make sure this says V4R, V8, and V9. You basically take your pen, relabel them once you do the second one. So very good. So that's what I would do. So yes, you are correct. This is this patient is having inferior wall MI, right? You know what else is important to note here, right? Look at lead 3. What do you notice between lead 2 and 3?
The ST elevation is greater in 3 than 2.
Yeah. So if I were to do this, by the way, when you guys start to do this, right, what you want to do is first you want to find the isoelectric line. When you're finding the isoelectric line, it's usually the previous T to P segment. So this is the previous T to P segment. So I know my isoelectric line has to lie somewhere here. And then when I establish this, the way to do this, I would just basically take I would run a EKG, then print out like a little bit more of a strip, a paper, and then I put that paper on top of my printed 12 lead. So I use that paper to kind of do that. So I'm not really drawing any lines because I'm going to show that to the physicians at the hospital. So when I fold this paper, all I do is I count how many boxes, right? So maybe this is with this and this, maybe this is 2 millimeter elevation, right? Maybe this is 1 millimeter elevation. But I definitely could say lead 3, right, is definitely more elevation than lead 2. And if we go back to our prior chart, right, notice how it says St segment elevation in lead 3 is greater than lead 2, is right coronary artery, very specific and sensitive. And also it says, if you look here, St segment depression greater than 1 millivolts in lead 1 and AVL or both, right? It adds right to it. So greater than lead 3 greater than 2 plus St segment depression, reciprocal changes, right? The chances of this having positive predictive value is 94%, right? So that's right coronary artery. So let me go back to that 12 lead EKG, right? So that's what you see here. Right, we see reciprocal changes, we see elevations, definitely transmit this, right? So very good. So your field diagnosis would be STEMI, right? MI, STEMI MI, contact medical control. What treatments would you give this person? Let's say this person had, we did the 15 lead EKG, there was no right ventricular involvement, right? And your blood pressure on this person was 110/82. What treatments would you render? Brenda, you wanted to go?
I was thinking about nitro.
So what would be your first drug you want to give? What would be number 1 drug?
Oxygen.
Aspirin.
Oxygen. As long as their pulse ox is less than 90% per the AHA, right? So yes, oxygen would be my first drug in a primary assessment. If their pulse ox is less than 90, let's say we gave that, what would be your follow-up drugs?
Aspirin.
Aspirin, how much?
162.
So per your protocol, use your REMAC protocol.
320, was it 325?
324 milligrams. Aspirin, right? And this is the only drug that reduces mortality by about 25%. So this is the number 1 drug I give after making sure that, pulse ox is less than 90. I give oxygen first, then I give my aspirin. Can I give nitro? Can I give nitrates in this case with no RVI and this blood pressure?
It's an inferior wall MI, so nitro would bottom him down,
So
and it wouldn't be good.
So right, even nitros can decrease his blood pressure, but because we don't have right ventricular involvement, right? Maybe his lesion is distal, right? His lesion is distal. He doesn't have elevations in V4R. He doesn't have posterior wall involvement. So his lesion could actually be somewhere here. Let me show you on this. It could be this one, right? So his lesions can be lower down, right? His lesions can be somewhere here or here. It's not taking a hit of the posterior wall. We don't have the right ventricular involvement, right? So here I could actually, as long as I have IV access, I would give him nitrates, right, for this patient. So nitrates I would administer as long as there's no RVI and this blood pressure is up and my IV is in place, right? So
only for RVI, you wouldn't give nitro.
Yeah, RVI, yeah, and posterior wall involvement, I would, especially RVI. This is where because why? Because right ventricle is preload dependent. I give you nitrates, I vasodilate, right? I drop your preload, and that's going to be a problem. Make sense? Right. This EKG was this was my 12 lead EKG I did in the field, right? This well, let me ask you guys, what do you see here?
There's elevations in the AVF and on the 4th lead.
Okay. You said V4? So let me make it a little bigger. So truly speaking, let me make this like that. So look here.
So you have elevations in 3 and AVF, and you see towards the end of 2 no, to 3, whichever one that is, right at the top, right on the right-handed side.
This? No.
No, not that one. The next one down.
This one.
So I think that's 3. No, you was on the right side, just down.
Tell me the lead number. Which lead?
I think that says 3. Yeah, it says 3.
3.
I'm sorry.
3, yeah.
Yeah, so you have some. No, the one. So what's that one in the middle? Because that looks like 4.
2. This is just
Oh.
ISO. This is 1. This is 2.
Oh,
this is
okay.
3.
Yeah, that was looking like a 2. All right, so you have some slight elevations
Yeah.
in 2, 3, and AVF. So
Yeah.
you already know
Yeah.
off this, you could just tell that it is an inferior
And you
wall
have-
MI.
And what's
You
happening
have
here?
depressions. You have
Yeah.
And you have
depressions in 1
depressions
and
in-
AVL.
And
Yeah.
one in AVL.
Yeah. So yes. But what do you notice about the heart rate?
It's 91.
Right. So heart rate is 91. Right. So a little bit below 100. Usually, right. I said that if you have a proximal, if you have higher up RCA involvement, it's going to occlude the SA node. Right. So do we have occlusion of the SA node here? Probably not, right? Because my heart rate is in the SA nodal range, 60 to 100. So this is probably more distal, right? Inferior wall MI. And this patient actually, what I want to tell you guys, this patient did not complain of chest pain. They had atypical symptoms. So in my lecture, I was explaining to you, right? Especially females, they'll complain of fatigue. They'll complain of abdominal, problems, indigestion, things like that. And so on those patients, especially diabetics, elderly, female, right? You want to be cautious, right? If they tell you, right, they're having any type of, symptoms of that nature, you want to run a 12 lead EKG, right, for them to find out if they have MI or not. So this person definitely went to the cath lab, right? But this person did not have chest pain. So if you dismiss their GI complaints, you dismiss their fatigue, and you don't run a 12 lead, right, you will miss your 12. You will miss your MIs, and they're not always like, tombstone type of, fireman's hat type deal, big. Sometimes they're subtle, but there's enough of elevations to, diagnose this, right? So that's how you want to look at the EKG, right? Right coronary artery, right? Heart rate is 91, so I know it's probably distal. I don't see. I did a 15 lead. There was no involvement. I didn't attach it here, but there was no V4R, V5, V6. This person got aspirin and nitrates. So that's how you want to be looking at that, right? Any questions here about this? I was looking at the interpretation for this one we just finished. So this 80-year-old male, his EKG was actually, when he went to the cath lab, they showed 100% occlusion in the right coronary artery at the cath lab. So this EKG here, right, was 100% RCA occlusion. And it makes sense, right? For all the things we said, 2-3 AVF elevations, lead 3 was greater than in lead 2. We have reciprocal changes. So this is clear cut, right? Especially with the setting of chest pain. All right, next we'll go to second question. Anyone would like to do it?
Can I go?
Yeah, go ahead. Go ahead, Jackson.
You perform a second ECG on the same patient 15 minutes later. Are there any changes? What medications must be continuous with?
What medications you must be cautious with? And
Caution.
I think I made a mistake here. It's consult medical control.
Consult medical control prior to administration of wine.
So let's first of all, right, see what's happening, right, in our follow-up EKG. So basically, we did a right-sided EKG. So here they didn't do a 15 lead EKG. What they did is they took all the leads from the left side and they placed them on the right side. So exactly how you do a 12 lead standard, you basically take all those leads, you put it on the right side, and that's why they relabeled this as V1R, V2R, and so forth. So basically this is looking at the right ventricle now. So we have right ventricular involvement, right? So what are the changes here?
Well, in V1, how it it's I can't really like point to it, but in V1 how it dips down and then it like makes a roll on top.
Like the elevation, right? The elevation.
Yeah.
So if I draw my isoelectric line, right? Yeah, these are elevated. V4R is elevated. So all of this is elevation. Plus you have elevations. Initially we said it was elevations in 2, 3 AVF. So this person was already having an inferior MI. Plus with these right-sided EKG leads, right? We can say he has right ventricular involvement. So if we go back to our initial chart here that we had, right? So let me erase some of this stuff so you guys can see it, right? So now we have right-sided involvement. So here, if you look, it says, in addition to the findings immediately above, so it was elevations 2, 3 AVF, you have St segment elevation in V4R, right, or V1 or both. So we definitely have V4R in addition to the above findings, right? So that tells me that is what? It's proximal. Proximal means closer to the trunk, right? Proximal means here, as opposed to distal is here. So this is distal, this is proximal. So what medications maybe we want to consider or potentially avoid giving this patient?
Well, we don't want to give him nitro.
Do we want to give him nitro or don't?
Don't.
Yeah, exactly.
No, yeah,
So,
don't. Yeah, don't.
Yeah,
don't
exactly. So the reason exactly, we don't want to give this person nitrates because he has right ventricular involvement. We said that's potentially dangerous. So this interpretation of this, right, it says if you have right ventricular involvement in association with inferior wall, there's a higher morbidity. Morbidity means death. Than as if it was isolated inferior infarction. So what they say is when you have this plus this, there's a higher chance of mortality for this person. And it makes sense because if you have right ventricle that took a hit, there's less preload that's coming in. So that's more worrisome, right? So we want to be cognizant of that. We see also, right, it could be right coronary or it could be the left circumflex that can also be feeding the inferior wall MI, right? So this could be a full right coronary artery inclusion, plus you may have a lower portion of the circumflex that's also is infarcted, right? You may also see reciprocal changes in these leads. So you may have V1 through V2, V3 depressed, right? Like we saw on this EKG here, right? So these leads could also be depressed, but they are not in this particular case. All right. Any questions?
So
Go ahead, Jackson.
with this patient, what medication would you consider?
So this person would still receive aspirin if they don't have no allergies for it. They'll still receive oxygen if their saturation is less than 90%. So they'll get O2. They'll get aspirin, 324 milligrams.
Is there any other medication that you can administer in the pre-hospital setting?
Yeah. If they have active vomiting, and they don't have prolonged QT interval, which this EKG doesn't show, they could also get Zofran. Right? Or it's called ondansetron. You want to make sure there's no prolonged QTC interval, right? There's not prolonged QTC interval. You're going to give it an increment so they don't vomit, 0.1 milligrams per kilogram. You don't want to exceed 8 milligrams in total with your administrations. And the other medications that you may consider would be nitrates, but nitro, I would be cautious about giving this person because they have positive right ventricular involvement.
Would you consider like fentanyl if they were complaining of severe pain?
You could call, but at your point, it will be a discretionary order. So when you're making your totally transition and you transmit, yeah, you could ask for pain medication. You could ask for fentanyl. Fentanyl would be more appropriate if their blood pressure was lower. So you could ask for discretionary order for pain. But in terms of if we look in terms of mortality, right? So what you're talking about is comfort measures, right? And I'm not disregarding them, but the way you want to be approaching this is first you want to address life-saving measures or those measures that will decrease mortality. What decreases mortality is aspirin 324 milligrams, early 12-lead transmission and acquisition, and rapid transport to the receiving facility. Sometimes, I'll be honest with you, I'll give the aspirin, oxygen, and I'll transmit. I don't have enough time to start my IV access on scene. I will move my patient to the ambulance, and I will initiate my transport. So I'll get my IV as we're driving to the cath lab or the hospital that we were told to transport this patient to. IV access will be started en route, right? And sometimes by the time I do that, we're almost at the hospital or very nearby. So sometimes you may not have the time frame to give your IV medications like Zofran, but now you could give it PO. Actually, this medication can be given PO, even though it's an IV formulary. But sometimes you may not have enough time to give your, pain medications. But my advice to you would be first focus on what's going to be life-saving treatment, and then comfort measures is second. Because if I do it the other way, you will have comfortable person who is going to be dead. All right. Any other questions?
Yes. So in the first strip here, V1, the T looks sinusoidal already, right? Is that just because it's elevated that way and it's kind of okay? It's not electrolyte imbalance.
No,
or could it be?
That's not electrolyte imbalance. It does look elevated to me here, right? So here, and that could also be, you may have elevations in V1. This is also suggestive of RV infarction. So RV infarction can show you that. So this is elevation. This is not T-wave abnormality. This is actually ST segment elevation in V1. So the way they fully interpret this, they say this shows you inferior wall MI with ST segment elevations in lead V1, suggestive of right ventricular infarction. And after placement on the right side 12 lead, this person showed right ventricular involvement with ST segment elevations on the right side. So yeah, this here is indicative of right ventricular involvement.
Okay.
Yeah. This is not T-wave abnormality. Any other questions about this?
I have one question.
Yeah.
And I probably missed it before. For doing the right side EKG, you would swap everything around, correct? So like you would swap V1 and V2 around and then just mimic the left side to the right side, correct?
So here, based on this picture, what they did was they took, for this particular example, they took everything off the left side and they put it in the exact same configuration, just on the right side, and they relabeled it. What I'm telling you guys to do is you don't have to do that. What you can do is you could do the 15 lead EKG, where you basically take the standard one, you take the V4, right, and you move it here, so you get V4R. This is AHA did a study. This one lead alone was over 80% specific to right ventricular involvement. You only need one lead, so you need V4R. If you have elevations in V4R, it's enough to know that they have right ventricular involvement. And then what I do is I take V5 and V6, I put it in the back of the patient, right? I relabel them as V8, V9 to get the posterior wall, right? So I see if there's a back wall involvement, right? Posterior wall of the heart is involved. So I don't really do a full-sided right side. I only do V4R, and then I'll do V8, V9 to get the posterior look. It's faster to do, gives you the same prognostic value as doing the right side, plus it gives me the posterior wall. All right. All right. Any other questions, or you guys are good? All right. If there's no other questions, we're going to go to question number 3. And let's see. If you want to raise your hands, I will call on one of you guys to do. And you could, even if you are not correct, you just give me your thought process. That's, that's what all I ask. I'm not asking you to be like, expert at this.
I'll do it.
All right, go ahead, Milan.
All right, so a 52-year-old man presenting with chest pain after performing 12 lead EKG. What is your field diagnosis? Is this patient having a STEMI? Which coronary artery, if any, is involved? All right, so there is definitely elevation in V1, 2, 3, 4. So that's anterior wall.
Which coronary artery?
It's anterior septal, so that might be left.
The left coronary artery, but any specific branch?
The
left coronary artery has 2 branches, the circumflex and the LAD.
LAD,
okay. So truly speaking, so Milan, you're not wrong what you said, but V4 doesn't really have elevations. The true elevations is here, right? V1, V2, V3. I'm not saying V4 is not. It looks like a hyperacute T wave, meaning like it will probably be elevated. But right now, I can't really, right? Because we said it's from here to here. It's not. I cannot really say distinctly it's elevated. Where here you have elevations. Here you have elevations. Here you definitely have elevations.
Is there prolonged QT in 3?
In 3, no, that it doesn't look prolonged to me. So this patient doesn't look like he has a prolonged QT interval. By the way, if he had a prolonged QT interval, that's why we have other leads. I would verify, right? So I would look at other leads. You can't just have prolonged in one lead. You must have prolonged in all the leads. So I would look at all the leads to do it. Also in the hospital, you'll see when they get a patient, if this patient was already there before, they would look at their past EKGs to see if there's any changes. So they always compare old to new, right? So truly speaking, what this person has, this 52-year-old male, he has elevations in V1, V2, V3, as we see here, right? This is the LAD, the left anterior descending, right? And you could say it's the anterior septal MI. And when they took this patient to the cath lab, they found he had 100% occlusion in his distal LAD. So distal LAD, let me go back to this picture here, right? So this is your LAD, and distal LAD would be, going down here. So somewhere, or maybe even down here. So distal LAD, right, feeds your left ventricle, right? So the occlusion was either here or maybe here, and that's what they found. So V1, V2, V3 elevated. Do we see reciprocal changes? I don't see any reciprocal changes here, right? Yeah, there's no reciprocal changes. If we had reciprocal changes, they'll be in the inferior wall, but I don't see them there, right? I don't see any reciprocal changes, meaning St segment depression. I don't really see any St segment depression, right? What's the underlying rhythm? So if I look at my boxes, right, let's say anything that hits, okay, let's say this one hits exactly at this mark, 300, 150, 100. So this person is maybe 120. So they're having tachycardia, right? There could be compensatory response. Makes sense. They could be in cardiogenic shock. Left ventricular wall took a hit. I don't know their blood pressure, but let's say the blood pressure may be low, right? They're compensating, right? So 300, 150, 100. So maybe 110, 120. We definitely want to slow down the heart rate, right? In the hospital, they're going to give them possibly beta blockers. And you want to tell me why they want to slow down the heart rate?
So the preload and afterall could get better?
So remember your coronary arteries, right? They feed during diastolic phase of your cardiac cycle. So let me go back to this diagram here, right? So as I was explaining in the lecture, right, the coronary arteries, they come off the aorta and they come off the aortic ostia, right? So during systole, when the aortic valve opens, it kind of shuts, it blocks the flow of blood to these coronary arteries. But during the diastolic phase, right, when the aortic valve closes, it snaps shut, then this backflow of blood can fill your right coronary and your left coronary. So during diastolic phase is when the actual feeding portion of your coronary arteries occur. And if I have a heart rate that's very fast, I'm decreasing the diastolic phase when the heart can fill. So, and plus the heart just sustained an injury, just sustain a heart attack. So I don't want to stress the heart even further. So what this patient is going to get, they're probably going to get, some sort of a beta blocker to reduce the heart rate to both conserve the myocardial oxygen demand, right? So your O2 demand goes down on the heart, and also to increase the diastolic phase of your cycle, so the coronary arteries get fed more. Certainly, you're going to give them aspirin. Certainly, if the blood pressure is 100 or above, there's no RV involvement, you're going to give them nitrates, right? So yeah, this person had distal left anterior descending occlusion 100% in the cath lab.
Nick.
Yeah.
So you mentioned here, you would, I think you said you would suspect reciprocal findings in 2, 3, and AVF.
Yes.
Why reciprocal? Why not? And why not elevations?
Because if you had elevations, that then there would be a possibility that this person is having both vessels infarcted. So what you're saying, Milan, is this: let's say he had elevations here, right? Here, right? Can you have elevations here and here? If you had that, then what do you have is this: you have both blockage here and blockage here. Can this happen? Maybe, but it's unlikely, right? That you have a blockage in both coronary arteries. So what usually happens is, if you have a blockage here, the reciprocal side, right? This is if this side of the heart is infarcting, the opposite side of the heart will show you reciprocal changes, which is usually manifested as depressions. If you had elevations, then I suspect this vessel and this vessel is blocked. It's usually unlikely to have both coronary arteries blocked. I'm not saying it cannot happen, but it's probably, not a highly likelihood. But what's a good likelihood is this side is infarcted, and you see like mirror image changes, which will be manifested as St segment depressions. However, if your MI is not so large that you have very high St segment elevations, you may not always have reciprocal changes. Right.
So basically, if the infarction is in that portion, the ischemia and injury are going to just go around it, and that's what's manifesting, right?
Yeah, exactly.
Okay.
Yeah. Even though I don't see St segment depression, right now, it means it could be, like I said, this here is distal left anterior descending, right? And maybe as this is ongoing, maybe these segments will, elevate even higher. And then you'll start to see these segments depressed, right? So I'm not saying it may not occur, but right now I don't see it. For your purposes, you're going to treat them right if they're having chest pain. By the way, how many 12 leads should you do in the field? Let's say you come in, you have a positive 12 lead here, right? St segment, you transmit. Is that the only EKG you do? You could take off all the leads from the patient, disconnect them from the monitor?
Shouldn't be continuous?
Yeah, if you have a patient like this, the monitor stays on them the entire transport. To be quite honest with you, I would even place them on the pads, right? I would connect the pads to them because they may go into, a lethal dysrhythmia, which you may need to use your pads to cardiovert. I would do serial 12 lead. So I would do serial 12 lead. So this would be my initial, right? Then let's say we are moving this person. Let's say you have this gap when you're driving. Let's say there's traffic, or you can't get through, like you stopped, right? You're still going lights and sirens to the hospital, but let's say there's a gap. I'll do another 12 lead, and I'll certainly try to get one the moment the bus is parked. I'll do another EKG. At the bare minimum, you want to have at least one on scene and one before coming in. You also want to get it after your treatments are given, so that, you know, you, for a fact, you know, see and you're trending those changes. So what may happen is these elevations can increase. You may start to see ST segment depressions. Always good to have serial 12 leads so that you could refer back and see, you know, what's occurring. What you don't want to do, is this. Guy is having chest pain. You come in, you do a 12 lead. There's no ST segment elevation. You'll say, okay, he doesn't need to go to the cath lab. You disconnect the monitor, you take him off, right? Let's say you just give him aspirin, you bring him to a non-cath lab capable facility. You didn't bother to do a second EKG. You definitely didn't do one when you stopped at the hospital. You bring him inside the ER. The guy says, my chief complaint is chest pain. The nurse says Sst Ekg, that do an EKG, and he has ST segment elevation. So now you brought a person who didn't have ST segment elevation upon your contact, is now having ST segment elevation. You never done a 12 lead EKG, right? The serial one. And now you took him to the wrong facility. And that's a common occurrence. And make sure that's not you who does that. All right. Any questions about this, or we continue? All right. So no questions. We're going to go to number 4. If any of you guys want to raise your hands, you are more than welcome to go. I see who we got. We got Lindsay. Go ahead.
All right, I'll give this a try. So I see elevation in V1.
Can you read the question first, please?
Oh, yeah, for sure. A 65-year-old man presenting with chest pain after performing 12 lead ECG. What is your field diagnosis? Is this patient having a STEMI? Which coronary artery, if any, is involved? So it looks like V1 and V2, which would be the septal wall.
Okay.
With the left anterior standing artery.
Okay. Any other elevations that you see?
So V4, I see like a big spike. It's not as square.
So
V4
those are
and
called,
V5.
yeah, those are called hyperacute T waves. But what about lead V3?
Oh yeah, look at that. Yeah.
Yeah. So V3 is also elevated, right? So what else do you see here? Any other changes besides the elevations?
The elevation. I see depressions in 2 and 3 and AVF.
Right. Yeah. So those are the reciprocal changes, and most likely why you see that, right? And we didn't see in the previous EKG is that here the ST segment elevations are much more prominent. They're much more, bigger in amplitude, right? And there is a bigger portion of the heart that's involved. So here it's probably higher. The lesion is higher up. It's more proximal, right? Okay. What would be your underlying rhythm? Can you say, or it's too hard to right now for you?
Let's see. So I see there's a P wave. It's kind of close.
Yeah.
So that looks okay. It looks like it's firing, right? The QRS kind of small.
Yeah, that could be just the morphology and our rate, right? If we look at this complex, right, you see this is 300.
160.
Yeah, so it kind of falls exactly. Could be 150, right? 150, 160. Yeah. So this person is having tachycardia, right? Tachycardia. So
right.
300, 150. So it could be 160 between that point of them, right? So
it's a sinus rhythm.
Yeah, it's not a sinus rhythm because sinus is between 60 to 100. But what's our heart rate? Our heart rate is maybe 150 or above 150. So we can no longer call it sinus, right? Because the moment it exceeds 100, it has to be a tachycardia.
Got it.
So you could say sinus tachycardia, right? Because we have P waves, but it's not a sinus rhythm. Okay. Right? So this EKG is the actual interpretation here is basically elevations in V1, V2, V3, which we see here. We also see greater than 1 millimeter ST segment depressions in lead 2-3 AVF. So that pathognomonic for definitely they're having an acute MI. This person was found to have 100% occlusion in a proximal LAD. Right? Okay. So they don't have, if you look here, that doesn't seem like they have lateral wall, right, involvement per se right now. But this this may get elevated later, but right now I don't see any elevations in here in the lateral wall. So they say 100% proximal LED, 100%
And you would say
proximal.
it's the septal wall and the anterior wall?
Correct.
Yeah.
Septal and anterior wall is involved. So when they say proximal LAD, right? So proximal LAD would be right here. So this is your LAD. This is your septal wall. This is your anterior wall. So the entire portion of this is involved. But the blood flow for now to the circumflex seems to be all right, you know, based on the EKG pattern. The reason why we see reciprocal changes is this is like the opposite wall, right? Which is the inferior wall. And we see depressions in these leads. We don't see elevations, right? If we saw elevations, then it will be another vessels that's occluded. What is the likelihood of that happening? Not that high. I mean, I'm not saying it cannot happen, but what are the chances of you having thrombus formation in both coronary arteries at the same time? You know, I would be buying a lottery at that point as well, right?
So Nikolai.
Yeah.
So when it's 100% block, so that would be a third degree block?
No, 100. So when they say 100% block, so what they referring to 100% proximal LAD. So that means that vessel I was just drawing is there's a thrombus that's not allowing any blood flow to go distally. So 100% occlusion right here. Let me go back to that lead. 100% lesion means there's no distal blood flow. Heart block indicates underlying rhythm, like your 3 lead, shows you either no P waves or prolonged PR interval, right? So a heart block is different from occlusion of a coronary artery. Occlusion of a coronary artery means, let's say, if I say there's 100% occlusion of proximal LAD, that tells me there is a thrombus that's now forming here that's not allowing blood to go distally. There's no blood flow here. So all of this area is getting infarcted. Make sense?
Yes, and the third degree block has to do with the conductions.
Correct. It's third degree heart block. If you know how you have the SA node, you have the AV node. Actually, I have a picture here, right? You have the AV node and the SA node. When you have a third degree heart block, right? It means your conduction from the SA node to the AV node is cut off, right? So then you have atria that are beating at their own rate, and you have ventricles that are beating at their own rate. So you'll see atria heart rate being between 60 to 100, and then you have ventricular rate, which is going to be 20 to 40, and they're not going to be in communication with each other. So you have AV dissociation. So that they call it complete heart block or third degree heart block, and that could mean you have some lesions, but the way we determine heart blocks is based on a underlying rhythm, right?
Right.
Like,
Thank you.
Yeah. Mm-hmm. All right. So let me go back to that. All right. Any questions about this one?
I got a quick question, right?
Yeah.
About lead 4. Now,
Okay.
Now you said that lead 4 is not technically elevation.
Yeah.
Why is that? Is it because of the fact that it goes up and it comes back down? Because I know in most ST elevations that it goes up, it elevates, and then it comes back down halfway. Yeah. Is that the reason why?
Yeah. So the reason why you see this morphology, this is they call this hyperacute T wave. This could mean that in a few minutes or hours, if this lesion is not corrected, this morphology is going to become this with elevation. You see how it's looking?
Okay, I see how I see what you're saying.
So right now there's no elevation. So this is elevation, right? You see how it's elevated here? This St segment is definitely elevated, right? It's elevated here. But here I cannot really say because my isoelectric line, somewhere here, right? The T wave looks hyperacute, but there's no elevation per se. But this is very indicative that it can elevate if we don't do anything about it. So we usually call this hyperacute T wave.
Because technically, it's the elevation starts at the isoline.
Yeah, that's what correct. Isoline of the St segment, right? So if we, if we say, let's say, P, Q, RST, right? So we're looking at this segment that's elevated, but it's not elevated here that I can see. But here, if I do this, right, we see that this is not on the isoelectric line. So I could say this is elevated. Same thing here, right? You see how this is the isoelectric line and this is elevated?
Got you. I got you. I see what it is now.
Yeah. So this is the STEMI.
So the T wave basically distorts the whole
Yeah.
arc.
Yeah. So they will call it hyperacute T wave, right? And this if we don't do anything about it is going to become this. Right? So time is muscle. All right. Any other questions? All right. So we move on to next one.